Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of homocystinuria for general pediatricians. This lecture covers 12 carefully crafted clinical cases addressing the major subtypes of homocystinuria, including cystathionine beta synthase deficiency and methylene tetrahydrofolate reductase deficiency. We will explore clinical presentation, pathophysiology, biochemical distinctions, newborn screening interpretation, diagnostic workup, treatment strategies including pyridoxine trials and dietary management, cardiovascular complications, and pregnancy management. Let us begin. Case 1. A 3-week-old male infant is referred for progressive neurological deterioration. He was born at term after an uncomplicated pregnancy. Parents report poor feeding since birth, increasing irritability, and 2 witnessed tonic-clonic seizures in the past 48 hours. On examination, head circumference is below the 3rd percentile consistent with microcephaly. Hypotonia is noted and the fontanelle is normal. Labs show plasma homocysteine is markedly elevated, plasma methionine is low, and cerebrospinal fluid 5-methyltetrahydrofolate is low. Newborn screening was flagged at day 5 showing low methionine and elevated homocysteine. What is the most likely diagnosis in this neonate? Option A. Methylene tetrahydrofolate reductase deficiency. Option B. Cystathionine beta synthase deficiency. Option C. Pyridoxine-dependent epilepsy. Option D. Maple syrup urine disease. The correct answer is Option A. Methylene tetrahydrofolate reductase deficiency. This enzyme converts 5,10-methylene tetrahydrofolate into 5-methyltetrahydrofolate, the active folate form. When this enzyme is deficient, homocysteine cannot be remethylated back to methionine, so homocysteine accumulates in blood and cerebrospinal fluid while methionine levels fall. Low methionine combined with low 5-methyltetrahydrofolate disrupts central nervous system development. Neonatal features include microcephaly, seizures, feeding difficulties, and developmental delay. The table on this slide shows that early diagnosis and treatment dramatically reduce complication rates. Remember the key clinical pearl: methylene tetrahydrofolate reductase deficiency causes low methionine, while cystathionine beta synthase deficiency causes high methionine. This biochemical distinction is diagnostic. Case 2. A 12-year-old boy presents with sudden blurring of vision in both eyes over the past 3 months. He is tall for his age with long, slender fingers. His mother reports he has always been a slow learner. Slit lamp examination reveals bilateral downward and nasal lens dislocation. Labs show plasma homocysteine is markedly elevated and methionine is markedly elevated. There is no family history of eye disease. What is the most likely underlying diagnosis? Option A. Methylene tetrahydrofolate reductase deficiency. Option B. Marfan syndrome. Option C. Cystathionine beta synthase deficiency. Option D. Ehlers-Danlos syndrome. The correct answer is Option C. Cystathionine beta synthase deficiency. This is the most common cause of classic homocystinuria. It causes markedly elevated homocysteine and methionine levels. The hallmark ocular finding is ectopia lennis, where the lens dislocates downward and nasally, also called inferonasally. This direction of dislocation is critical for distinguishing homocystinuria from Marfan syndrome, where the lens dislocates upward and temporally, also called supratemporally. Homocystinuria is autosomal recessive with elevated homocysteine, while Marfan syndrome is autosomal dominant with normal homocysteine levels. If untreated, patients face thromboembolic events and intellectual disability. This condition typically presents in childhood or adolescence. Case 3. A 10-year-old boy is referred for tall stature evaluation. His height is 158 centimeters, above the 97th percentile. Examination reveals long limbs, arachnodactyly, pectus excavatum, and a high-arched palate. Labs show plasma homocysteine at 185 micromoles per liter, which is markedly elevated, and methionine is elevated. Slit lamp examination shows bilateral downward lens dislocation. Which single feature best distinguishes this patient's condition from Marfan syndrome? Option A. Joint hypermobility and aortic root dilatation. Option B. Upward lens dislocation and tall stature. Option C. Autosomal dominant inheritance pattern. Option D, presence of osteoporosis on spinal imaging. The correct answer is option D, presence of osteoporosis on spinal imaging. While homocystinuria and Marfan syndrome share many features such as tall stature, arachnodactyly, pectus deformities, and scoliosis, osteoporosis is a key distinguishing feature found in homocystinuria but not in Marfan syndrome. Elevated homocysteine disrupts collagen cross-linking, weakens bone matrix integrity, and leads to vertebral collapse risk. In contrast, Marfan syndrome features joint hypermobility and aortic root dilatation. Other important differences include the direction of lens dislocation, which is downward and nasal in homocystinuria versus upward and temporal in Marfan syndrome. Homocystinuria is autosomal recessive with elevated homocysteine, while Marfan syndrome is autosomal dominant with normal homocysteine. Intellectual disability is common in homocystinuria but typically absent in Marfan syndrome. Case 4. A 6-year-old boy is referred for evaluation of developmental delay, tall stature, and a recent episode of deep vein thrombosis. Plasma amino acid analysis reveals total homocysteine is markedly elevated, methionine is markedly elevated, and cystathionine is undetectable. Vitamin B6 supplementation is initiated. Which enzyme is most commonly deficient in classical homocystinuria? Option A, cystathionine beta synthase. Option B, methionine synthase. Option C, methylene tetrahydrofolate reductase. Option D, beta-ine homocysteine methyltransferase. The correct answer is option A, cystathionine beta synthase. This enzyme catalyzes the conversion of homocysteine to cystathionine in the transsulfuration pathway. When cystathionine beta synthase is deficient, homocysteine and methionine accumulate while cystathionine becomes undetectable. This is the most common cause of classical homocystinuria. The consequences of homocysteine accumulation affect multiple organ systems: ocular involvement with ectopia lennis and downward nasal lens dislocation, neurological involvement with intellectual disability, seizures, and psychiatric issues, vascular damage leading to thromboembolism and stroke, and skeletal manifestations including marfanoid habitus, osteoporosis, and scoliosis. Remember the key distinction. Cystathionine beta synthase deficiency raises both homocysteine and methionine, while methylene tetrahydrofolate reductase deficiency raises homocysteine but lowers methionine. Case 5. A 3-month-old boy is referred after newborn screening flagged low methionine and elevated plasma homocysteine. His parents are consanguineous. On examination, he shows axial hypotonia and poor feeding. Plasma 5-methyltetrahydrofolate level in cerebrospinal fluid is markedly reduced. Which enzymatic step is deficient in this patient? Option A, conversion of homocysteine to cystathionine. Option B, conversion of methionine to S-adenosylmethionine. Option C, conversion of 5,10-methylene tetrahydrofolate to 5-methyltetrahydrofolate. Option D, conversion of S-adenosylmethionine to S-adenosylhocysteine. The correct answer is option C, conversion of 5,10-methylene tetrahydrofolate to 5-methyltetrahydrofolate. This step is catalyzed by the methylene tetrahydrofolate reductase enzyme. 5-methyltetrahydrofolate is the methyl donor needed for remethylating homocysteine back to methionine. When this enzyme is deficient, homocysteine accumulates while methionine levels fall. The result is neurological damage, vascular toxicity, and developmental delay. Option A describes cystathionine beta synthase function, not methylene tetrahydrofolate reductase. Option B describes the methionine adenosyl transferase step. Option D describes methyltransferase reactions from S-adenosylmethionine to S-adenosylhocysteine. The therapeutic implication is that beta-ine and 5-methyltetrahydrofolate supplementation can bypass the defective enzyme and help restore methionine levels. Case 6. A newborn male, 3 days old, has routine newborn screening results received. The newborn screening findings show methionine is low and total homocysteine is elevated. The sample was collected at 48 hours of life. Which metabolic disorder is most likely indicated by this newborn screening pattern? Option A, phenylketonuria. Option B, maple syrup urine disease. Option C, propionic acidemia. Option D, methylene tetrahydrofolate reductase deficiency. which is a type of homocystinuria. The correct answer is option D, methylene tetrahydrofolate reductase deficiency. The combination of low methionine plus elevated homocysteine on newborn screening is the classic pattern for a remethylation defect. Low 5-methyl tetrahydrofolate impairs the remethylation of homocysteine back to methionine. In contrast, cystathionine beta synthase deficiency shows high methionine, which is the opposite pattern. Cobalamin disorders such as complementation groups C, E, and G also cause elevated total homocysteine, but with distinct biochemistry. Immediate referral to a metabolic specialist is essential upon receiving an abnormal newborn screening result. The algorithm shown on this slide guides workup. Check methionine level first. If low or normal, suspect methylene tetrahydrofolate reductase deficiency or cobalamin disorders. If elevated, suspect cystathionine beta synthase deficiency. Then urgently obtain plasma total homocysteine, 5-methyl tetrahydrofolate, vitamin B12 levels, and gene sequencing. Case 7. A 3-week-old male is referred after abnormal newborn screening. Plasma homocysteine is markedly elevated. Plasma methionine is low to normal. Plasma 5-methyl tetrahydrofolate in cerebrospinal fluid is low. Methylene tetrahydrofolate reductase deficiency is suspected. Newborn screening is not diagnostic alone. What is the gold standard confirmatory workup for methylene tetrahydrofolate reductase deficiency? Option A, plasma total homocysteine plus methylene tetrahydrofolate reductase gene sequencing. Option B, urine organic acids plus plasma amino acid chromatography. Option C, plasma methionine level alone plus dietary trial. Option D, serum folate plus red blood cell folate levels only. The correct answer is option A, plasma total homocysteine plus methylene tetrahydrofolate reductase gene sequencing. Plasma total homocysteine is markedly elevated, often above 100 micromoles per liter in methylene tetrahydrofolate reductase deficiency. Gene sequencing identifies biallelic pathogenic variants, confirming the diagnosis definitively. Low plasma 5-methyl tetrahydrofolate in both cerebrospinal fluid and plasma supports the presence of a remethylation defect. Methionine levels are low or normal, which distinguishes this from cystathionine beta synthase deficiency, where methionine is high. The confirmatory diagnostic algorithm proceeds from dried blood spot newborn screening to plasma biochemistry confirmation and finally to gene sequencing for definitive diagnosis. If sequencing is negative, deletion and duplication analysis should be performed. Case 8. A 17-year-old male presents with sudden onset of right-sided weakness and speech difficulty, lasting 2 hours before partial resolution. He has a history of mild learning difficulties since childhood and no cardiac history. Examination reveals a tall, slender build with arachnodactyly and mild residual right hand drift. Labs show plasma total homocysteine at 148 micromoles per liter, which is significantly above the normal value of less than 15. Brain magnetic resonance imaging shows an acute left middle cerebral artery territory ischemic stroke. What is the most likely cardiovascular complication responsible for this presentation? Option A, aortic root dilatation with acute dissection. Option B, hypertrophic cardiomyopathy with outflow obstruction. Option C, thromboembolic stroke due to hyperhomocystinemia. Option D, paradoxical embolism through a patent foramen ovale. The correct answer is option C, thromboembolic stroke due to hyperhomocystinemia. Homocysteine directly damages endothelial cells, triggering oxidative stress and vascular inflammation. It promotes a hypercoagulable state through platelet activation and reduced anticoagulant factors. Both arterial and venous thrombosis can occur, and stroke is a classic presenting event in homocystinuria. Cystathionine beta synthase deficiency carries the highest thromboembolic risk among all homocystinuria subtypes. Why not the other options? Aortic root dilatation is a feature of Marfan syndrome, not homocystinuria. Pulmonary fibrosis is not associated with homocystinuria. Hemolytic anemia is not a primary complication of homocystinuria. The pathway shown on this slide illustrates how elevated homocysteine leads to endothelial injury, platelet activation, thrombus formation, and ultimately stroke or deep vein thrombosis. Case 9. A 7-year-old boy is newly diagnosed with homocystinuria due to cystathionine beta synthase deficiency after presenting with ectopia lennis and mild developmental delay. Plasma total homocysteine is markedly elevated. He has no prior treatment. What is the most appropriate first-line intervention to trial in this patient? Option A. Initiate lifelong betaine supplementation immediately. Option B. Administer high-dose pyridoxine, which is vitamin B6, trial for 4 to 6 weeks. Option C. Begin strict methionine-restricted diet without any supplementation. Option D. Start anticoagulation therapy to prevent thromboembolic events. The correct answer is option B, high-dose pyridoxine trial, also known as vitamin B6 trial. Approximately 50% of patients with cystathionine beta synthase deficiency are pyridoxine responsive. Vitamin B6 acts as a cofactor for the cystathionine beta synthase enzyme and boosts residual enzyme activity. The trial involves administering high-dose vitamin B6 at 200 to 1,000 milligrams per day for 4 to 6 weeks while monitoring plasma homocysteine. Responders show normalization of total homocysteine and should continue vitamin B6 lifelong. Non-responders require addition of betaine plus a methionine-restricted diet. Importantly, pyridoxine is not effective in methylene tetrahydrofolate reductase deficiency. Prolonged high-dose vitamin B6 without biochemical response should be avoided due to the risk of peripheral neuropathy at high doses. Case 10. An 8-year-old boy with confirmed cystathionine beta synthase deficient homocystinuria was found to be pyridoxine non-responsive after a 6-week trial. His plasma homocysteine remains elevated at 180 micromoles per liter. He is growing well, but his metabolic team is reviewing his long-term nutritional strategy. Which dietary management approach is the cornerstone of long-term treatment for this pyridoxine non-responsive patient? Option A. High-protein, high-methionine diet to compensate for metabolic losses. Option B. Unrestricted diet with betaine supplementation alone. Option C. Protein-free diet with total parenteral nutrition support. Option D. Methionine-restricted diet with methionine-free amino acid formula supplementation. The correct answer is option D, methionine-restricted diet with methionine-free amino acid formula supplementation. Dietary methionine restriction is the cornerstone of long-term homocystinuria management. High methionine intake gets converted to homocysteine, which worsens toxicity. The goal is to maintain plasma methionine in the upper normal range. Patients must supplement with methionine-free amino acid formula to meet protein needs. High-protein foods like meat, eggs, dairy, and legumes are strictly limited. Low-protein specialty products such as low-protein bread, pasta, and rice cakes are essential, not optional. Fruits and vegetables are low in methionine and can be eaten freely. This diet must be managed by a metabolic dietitian with regular biochemical monitoring of plasma methionine and homocysteine every 3 to 6 months. Betaine alone without dietary restriction is insufficient for cystathionine beta synthase deficiency. Case 11. A 9-year-old boy with confirmed methylene tetrahydrofolate reductase deficiency has persistently elevated plasma homocysteine at 142 micromoles per liter despite L5-methyltetrahydrofolate and vitamin B12 supplementation. His metabolic team considers adding betaine to his regimen. Through which mechanism does betaine primarily reduce homocysteine levels in this patient? Option A. Remethylation of homocysteine to methionine via the betaine homocysteine methyltransferase pathway, using betaine as the methyl donor. Option B. Transsulfuration of homocysteine to cystathionine via cystathionine beta synthase enzyme activation. Option C. Direct inhibition of homocysteine synthesis by blocking S-adenosylmethionine recycling. Option D. Enhancement of methylene tetrahydrofolate reductase enzyme activity to increase 5-methyltetrahydrofolate production. The correct answer is option A, remethylation via the betaine homocysteine methyltransferase pathway. Betaine donates a methyl group to homocysteine, converting it to methionine. This reaction is catalyzed by betaine homocysteine methyltransferase, an enzyme expressed primarily in the liver. This pathway completely bypasses the defective methylene tetrahydrofolate reductase enzyme. Betaine is effective in both cystathionine beta synthase deficiency and methylene tetrahydrofolate reductase deficiency. It reduces plasma total homocysteine levels. Option B is incorrect because pyridoxine is the cofactor for cystathionine beta synthase, not betaine's mechanism. Option C is incorrect because 5-methyl tetrahydrofolate supplementation bypasses via methionine synthase, not via betaine homocysteine methyltransferase. Option D is incorrect because methionine restriction reduces substrate, not betaine's mechanism. Betaine dosing is 100 to 150 milligrams per kilogram per day. Case 12. A 28-year-old woman with known homocystinuria due to cystathionine beta synthase deficiency presents at 32 weeks gestation for routine metabolic follow-up. She was diagnosed at age 6 via newborn screening and has been on a methionine-restricted diet. Current labs show plasma total homocysteine at 78 micromoles per liter, which is elevated, and plasma methionine at 420 micromoles per liter, which is also elevated. There are no neurological symptoms, and fetal growth is appropriate. Which of the following is the most appropriate management strategy for this patient during the 3rd trimester and postpartum period? Option A. Discontinue betaine supplementation to reduce methionine levels and prevent fetal toxicity. Option B. Initiate low molecular weight heparin prophylaxis and intensify metabolic monitoring of homocysteine and methionine levels. Option C. Switch to a high-protein unrestricted diet to support fetal growth and discontinue all metabolic supplements. Option D. Perform immediate cesarean delivery to prevent thromboembolic complications regardless of gestational age. The correct answer is Option B. Initiate low molecular weight heparin prophylaxis and intensify metabolic monitoring. Pregnancy in homocystinuria significantly increases thromboembolic risk, especially in the 3rd trimester and postpartum period. The pregnancy management checklist includes monitoring plasma homocysteine every 4 to 6 weeks throughout pregnancy, continuing betaine supplementation with dose adjustments to maintain homocysteine control, daily folic acid and vitamin B12 supplementation for remethylation support, adjusting methionine intake as requirements increase in the 2nd and 3rd trimesters with dietitian review, initiating low molecular weight heparin prophylaxis from 28 to 36 weeks gestation, continuing until 6 weeks postpartum, and ensuring high-risk obstetric co-management with both metabolic specialists and maternal fetal medicine. Treatment must never be discontinued during pregnancy. Lifelong metabolic control is essential. Before we move to the final summary, here is a quick note about our Pediatric Case Review community on Patreon. In our Patreon community, you will find all videos organized by body system, so you can easily access all lectures in one place. Plus, all presentations used in the videos are available as high-quality images, perfect for offline review and practice of all questions. If you are interested in details and how to subscribe, simply comment below in this post, and we will message you directly. Your support helps us continue creating high-quality medical education content. Here are the 4 key clinical takeaways that every general pediatrician must remember about homocystinuria. Number 1. Screen early. Newborn screening detects homocystinuria before symptoms appear, and early treatment prevents irreversible damage. Number 2. Spot the lens. Ectopia lenis in a child means homocystinuria until proven otherwise. Refer urgently to ophthalmology and metabolic specialists. Number 3. Treat multimodally. The approach includes betaine, methionine-restricted diet, vitamin B12, and folate. Tailor therapy to the specific enzyme defect. Number 4. Monitor for life. Biochemical surveillance is lifelong. Homocysteine control prevents strokes and other serious complications. Thank you for joining this Pediatric Case Review lecture on homocystinuria. We hope this comprehensive case-based review has strengthened your understanding of the clinical presentation, biochemical distinctions, diagnostic workup, and management strategies for this important metabolic condition. These lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. Please follow the Pediatric Case Review channel for more informative presentations. If you have any questions or suggestions for future topics, please comment below. See you in the next lecture.